Dear students, this is lecture number 2 for glaucoma. In this lecture, we are going to discuss one variant of primary open-angle glaucoma, which is normal tension glaucoma, primary angle closure glaucoma, the most important 5 types of secondary glaucoma, lastly, congenital glaucoma. Normal tension glaucoma is also called low tension glaucoma. It is exactly similar to the clinical manifestation of primary open-angle glaucoma, except that the intraocular pressure is equal or even less than 21 mm mercury. The exact cause of normal tension glaucoma has not well understood, and various mechanisms has been postulated, such as vascular insufficiency of retinal and optic nerve blood vessels. Also, there is decrease in optic disc resistance to the ischemic and mechanical theory of primary open-angle glaucoma. The intraocular pressure, although it is normal in patients with normal tension glaucoma, but still affecting the perfusion pressure of retina and optic nerve head. For this reason, in treatment of those patients, we need to lower the intraocular pressure even more. Still, there is a theory mentioned that there is a compression on the optic nerves by carotid arteries in the roof of cavernous sinus and middle cranial fossa. We diagnosed and treat patients with normal tension glaucoma in similar way to the patients with primary open-angle glaucoma. The second type of glaucoma is a primary angle closure glaucoma, which is a condition in which there is obstruction to the aqueous outflow due to partial or complete closure of the angle of the anterior chamber by the periphery of the iris. The diagnosis of primary angle closure glaucoma is by signs and symptoms, examination of the anterior segment, and gonioscopy. Unlike primary open-angle glaucoma, which is usually diagnosed by assessment of the optic nerve head, visual field, and corneal thickness. There are 3 anatomical predisposing factors for development of primary angle closure glaucoma, which are relative anterior location of iris lens diaphragm, shallowing of the anterior chamber, narrowing of the entrance to the angle of the anterior chamber. These 3 predisposing factors are usually present in patients with high hypermetropia due to the shortening of the anterior-posterior diameter, and also in patients above age of 65 because there is enlargement of the size of the lens. So when there is mid-dilatation of the pupil, for example, a patient watching TV in dark room, during anxiety when there is a release of catecholamines, so there is mid-dilatation of the pupil. And in the presence of shallow anterior chamber, there is a direct position between the pupillary margin and the anterior capsule, lead to pupillary block and accumulation of the aqueous in the posterior chamber and anterior bowing of the iris. This anterior bowing is called iris bombae. More release of aqueous in the posterior chamber lead to more bowing of the iris and direct contact between the cornea and the periphery of the iris and occlusion to the angle of the anterior chamber, and sudden rising of intraocular pressure might reach 50 mm mercury or even more. This is a slit lamp examination of normal person. So if we put the slit lamp examination on the temporal periphery of the cornea, we have two slits. This is one slit, this is a second slit. The first slit, this one, represents the thickness of the cornea. This is the thickness of the cornea, while this slit on the anterior surface of the periphery of the iris. Then we compare this black distance, which represents the angle of the anterior chamber between the endothelium of the cornea and the anterior surface of the iris, to the thickness of the cornea. If this distance is larger than the thickness of the cornea, like in this patient, in this human, so it means the angle of the anterior chamber is normal or wide. But if we see the next slide, which is a patient with narrow angle, so you can see the distance, the black distance between the endothelium of the cornea and the anterior surface of the iris is less than the thickness of the cornea. It means this patient having a narrow angle of the anterior chamber, and he is predisposing for development of angle closure glaucoma. This test is called Van Herk test. For you in the future as a first day doctor, if you have no slit lamp for assessment of the depth of the anterior chamber, we have a rough method for assessment of the depth of the anterior chamber. For example, here we have deep anterior chamber. There is a large distance between the cornea, this is the cornea, and this is the iris. So you can see wide depth of the anterior chamber. While in this patient, there is anterior bowing of the iris, and there is a very narrow anterior chamber. So just when you shine your light of your torch on the temporal side of the limbus in tangential way to the plane of the iris, you can see illumination of the whole iris, temporal side and nasal side. But if you shine your torch from the temporal side for the patient with narrow angle of the anterior chamber, you can see there is illumination of the temporal side of the iris and darkness of the nasal part of the iris, in similar way to the relation between sunlight and earth. So you can see half of the earth having daytime and the other half is night time. Like in patients with primary open-angle glaucoma, also here all patients need to assess the angle of the anterior chamber. So by using a slit lamp and gonio lens, we can see the pupil here. This is the iris, this is the extreme periphery of the iris, and this is the angle of the anterior chamber. This is the cornea. So we cannot see any details of the angle of the anterior chamber. I mean, there is no Schwab's line, trabecular meshwork, scleral spur, or the anterior surface of the ciliary body. This is one of the important variants of primary angle closure glaucoma, which is acute congestive angle closure glaucoma. This condition is usually caused by sudden total closure of the angle of the anterior chamber, and there is sudden rising of intraocular pressure more than 50 mm mercury. Unlike primary open-angle glaucoma, which is usually symptomless, here there is a severe symptoms. There is a progressive impairment of visual acuity, and this is due to rising of intraocular pressure, which lead to damage the endothelium of the cornea and corneal edema. Also, because there is severe rising of intraocular pressure, there is ocular pain, periocular pain, and there is severe congestion of the eye. Sometimes there is even nausea and vomiting, and most of those patients usually presented with headache. So you should put acute congestive angular closure glaucoma in the differential diagnosis of severe headache. Signs of acute congestive angular closure glaucoma include, by naked eye, there is congested conjunctiva, especially around the limbus, circumcorneal injection. The pupil looks mid-dilated, oval in shape, not reacting to light. By slit lamp, we have two slits. This is a corneal slit, and this is the iris plane. So the dark area, this dark area in between, represent a shallowing and narrowing of the angle of the anterior chamber. By gonioscopy, we cannot see any details in the angle of the anterior chamber. This is the iris plane, this is the pupil, this is the angle, this is the corneal tissue, and here is the angle. So we cannot see any details here for the angle of the anterior chamber. This is a slit lamp examination of patient with acute congestive angular closure glaucoma. You can see here there is congested conjunctiva even with subconjunctival hemorrhage here in this area. And also you cannot see the details of the iris in a clear view. This is because there is corneal edema due to severe rising of intraocular pressure. Again, you can see the pupil is mid-dilated, not well-dilated, mid-dilated. This is the critical position when there is direct contact between the pupillary margin and the anterior convexity of the anterior capsule. The treatment for acute congestive angular closure glaucoma is surgical, full stop. But we cannot do surgery on eye with severe rising of intraocular pressure and severely congested and inflamed eye. So first we should start medical treatment just to lower the intraocular pressure and to make the eye more quiet, and then surgical treatment should be done to the affected eye and to the fellow eye to prevent similar story. And the surgical treatment is either by simple method of neodymium, yttrium, aluminium garnet laser iridotomy, or by trabeculectomy. The first line of medical treatment is admission to the hospital because rising of intraocular pressure more than 50 mm mercury might lead to severe optic nerve damage within few hours or days, and also because carbonic anhydrase inhibitors and osmotic diuretics given IV, and it might create systemic side effect. Please to compare the topical drops which are using here with the topical drops used to treat primary open angle glaucoma. So you can see the difference that pilocarpine is used here as a first choice to abort the mid-dilated pupil to make a constriction of the pupil and create the passage for aqueous from the posterior to the anterior chamber. While the prostaglandin agonist, which is the first choice in primary open angle glaucoma, is the last choice here because it might create inflammation inside the eye. Also here we can use topical steroid to decrease inflammation, to control inflammation, and also to prevent adhesion between the iris and the lens and iris and the cornea, I mean anterior and posterior synechia. This slide shows peripheral ND-YAG laser iridotomy. which is usually done in outpatient clinic within few minutes, if not a few seconds. And this iridotomy should be done for both eyes, the eye with acute congestive angle closure glaucoma and the other eye to prevent similar attack in future. What is the mechanical benefit of creating peripheral laser iridotomy in patient with acute congestive angle closure glaucoma? See here, this is the outer layer of the eye, which is the cornea, and its continuation is the sclera. This is the transitional area, which is the limbus. Then this is the intermediate layer or coat of the eye. Here is the choroid, this is the ciliary body, and then the iris. This is the anterior chamber between the cornea and iris, and this is the posterior chamber between the iris and the lens and between the iris and zonules. So when there is mid-dilatation of the pupil, there is direct contact between the pupillary margin and the anterior capsule of the lens, and there is a pupillary occlusion preventing passage of aqueous from the posterior chamber into the anterior chamber. For this reason, there is entrapment of aqueous inside the posterior chamber, pushing the iris forward. This is called iris bombi, till there is occlusion to the angle of the anterior chamber by the periphery of the iris, and there is severe rising of intraocular pressure. So creating peripheral perforation or peripheral iridotomy give the aqueous another chance to pass from the posterior chamber into the anterior chamber through this opening, and then to the angle of the anterior chamber to be drained through the trabecular meshwork and the anterior surface of the ciliary body into the systemic circulation to control the intraocular pressure. But if this patient is left for days and without using steroid to avoid synechia and adhesion between the periphery of the iris and the cornea, which is called anterior synechia. So even perforation of the iris here, and the aqueous is coming from the posterior into the anterior chamber, the aqueous cannot pass through the angle to the trabecular meshwork and anterior surface of ciliary body, because there is a permanent anterior synechia between the periphery of the iris and the cornea. For this reason, we should treat those people in a fast way. It is worthy to do peripheral laser iridotomy for all patients presented with acute congestive angle closure glaucoma because it is a simple procedure for both eyes, the affected and the fellow eye. But if the management is delayed and there is permanent anterior synechia, so there is no benefit from peripheral iridotomy, but definitely the benefit is 100% to the fellow eye. And if you want to understand this surgical procedure, which is called the trabeculectomy, you can go to the first lecture because I discussed trabeculectomy in details in the first lecture of the glaucoma. So the aqueous is passed through the peripheral iridectomy, because here we cut surgically a part of the periphery of the iris, then through the trabecular defect between the scleral bed and scleral flap into subconjunctival space, and then into the systemic circulation by conjunctival blood vessels and episcleral veins. Secondary glaucoma is the glaucoma that associated with other cause or with other disease inside the eye, in addition to rising of intraocular pressure. There are many causes inside the ocular tissue that lead to rising of intraocular pressure, but I choose the most important 5 types of secondary glaucomas. Inflammatory glaucoma is the first type of secondary glaucoma. you can see here in this slide, there is adhesion between the pupillary margin and the anterior capsule of the lens. Also, there is pigmentation of the iris precipitated on the anterior capsule of the lens. Also, if you look to the color of the iris, it looks washed out or lighter than usual because there is chronic inflammation, chronic iritis. And by OCT of the anterior segment, this is the cornea, this is the anterior capsule. Also, you can see posterior synechia here and anterior synechia in this area. Why there is rising of intraocular pressure when there is acute or chronic inflammation of the iris? First of all, because there is many inflammatory cells and protein inside the aqueous, this cell might precipitate it at the angle of the anterior chamber, causing rising of intraocular pressure because of a pupillary block due to posterior synechia or occlusion to the angle of the anterior chamber by anterior synechia. We should not forget to remember that using topical steroid for months or years also another cause for rising of intraocular pressure in cases of inflammatory glaucoma. Neovascular glaucoma is the second type of secondary glaucoma, and by examination to the anterior segment you can see abnormal blood vessels on the surface of the iris, which is called rhopiosis iridis. Presence of rhopiosis iridis indicate retinal ischemia and release of vascular endothelial growth factor. We have many causes for ischemia to the retina and then neovascular glaucoma. The most important two causes are central retinal vein occlusion and proliferative diabetic retinopathy. But we have other miscellaneous causes, for example, carotid obstructive disease, central retinal artery occlusion, intraocular tumors, long-standing retinal detachment without treatment, chronic intraocular inflammation. The lens can induce secondary glaucoma by many mechanisms, include, for example, here there is what is called ectopia lentis, when there is weak zonules and subluxation of the lens, so the lens might move forward and incarcerated within the pupil, lead to blockage of passage of aqueous from the posterior to the anterior chamber and lead to pupillary block glaucoma. Sometimes when the lens having cataract, whether it is mature or immature, there is an abnormal permeability of the anterior capsule and the fluid pass from the anterior chamber into the lens, lead to swelling of the lens and pushing the iris diaphragm forward, lead to pupillary block and induce a glaucoma which is called phacomorphic glaucoma. The other mechanism, when there is hypermature cataract and there is abnormal permeability of lens particle from the anterior capsule, so there is release of these lens particles inside the anterior chamber, which is precipitated at the trabecular meshwork, lead to rising of intraocular pressure in phacolytic glaucoma. The other mechanism, when there is rupture to the anterior capsule, whether by surgery or trauma, and there is release of lens matter, not lens particles, lens matter, a huge amount of lens matter inside the anterior chamber. This lens matter regarded by the body as foreign body and induce antigen antibody reaction and severe inflammation and rising of intraocular pressure. This type of glaucoma is called phacoanaphylactic glaucoma. You can see here the lens particles fill the anterior chamber in phacolytic glaucoma. So there is rising of intraocular pressure because there is a precipitation of these lens particles at the angle of the anterior chamber. And even you cannot see any details for the iris because there is large amount of lens particles inside the anterior chamber. Then after resorption of these lens matter from the anterior chamber and passing through the trabecular meshwork, you can see here there is shrinkage of the lens and folding of the anterior capsule because the lens matter is released to the anterior chamber. So this is a phacolytic glaucoma, and here the treatment is to remove the lens by cataract surgery. You can see here there is a mature cataract and the lens is swollen, lead to pupillary block and lead to phacomorphic or intumescent glaucoma. If you send this patient for OCT of the anterior segment, so you can see there is an increase in the thickness of the lens. This is the posterior capsule and this is the anterior capsule. So there is widening of the thickness of the lens and the swelling of the lens, and also you can see the iris diaphragm is moved forward. There is a pupillary block. This is the cornea, and this is shallowing of the anterior chamber in phacomorphic or intumescent glaucoma. Just I forgot to mention that the treatment for phacomorphic or intumescent glaucoma is also by removing the lens with cataract surgery. Here in this slide there is a release of lens matter inside the anterior chamber due to the rupture of the anterior capsule by trauma. This lens matter regarded by the body as a foreign body, and there is an antigen antibody reaction lead to severe anaphylactic inflammation and severe rising of intraocular pressure. Again, the treatment here is to remove the lens matter and the lens as a whole by cataract surgery. In this slide, you can see the movement of clear lens as a whole to the anterior chamber, and there is a pupillary block. This pupillary margin behind the lens, and this is the margin of the lens. This is due to weak zonules, for example, Marfan syndrome or homocystinuria. This leads to pupillary block and induce severe rising of intraocular pressure, and also it induces myopia because there is a forward movement of the lens. For this reason, the treatment here is again lens extraction, although the lens is clear and not cataractous. The fourth cause for secondary glaucoma is pseudoexfoliative glaucoma. This is a common type of secondary glaucoma. This is occur in association with pseudoexfoliative syndrome. Pseudoexfoliative syndrome is a systemic syndrome involving all organs of the body, including the eyeball, specifically the anterior capsule of the lens, and there is release of dandruff-like material from the anterior capsule, and you can see these particles on the pupillary margin. This is whitish gray in color around the pupillary margin, and this is also particle of dandruff-like material. This material is also precipitated at the angle of the anterior chamber, lead to rising of intraocular pressure in pseudoexfoliative glaucoma. Usually this syndrome, this type of glaucoma is seen in patients above age of 40. If we dilate the pupil of patient with pseudoexfoliative glaucoma or pseudoexfoliative syndrome with topical medication, this is the maximum dilatation of the pupil with medication. So we can see two rings. This one is the inner ring and the other one is the outer ring, continuous outer ring. Those two rings occur because of the movement of the pupillary margin between maximum dilatation in darkness and maximum meiosis and intense illumination. So there is exfoliation of the area in between and accumulation of dandruff-like material in the inner ring. The treatment for pseudoexfoliative glaucoma is not lens extraction, like other types of lens-induced glaucoma, is by medical or surgical treatment in similar way to the patients with primary open-angle glaucoma. The fifth and the last type of secondary glaucoma is pigmentary glaucoma. This type of glaucoma usually occurs in patients with deep anterior chamber, for example, patients with high myopia. So here you can see this is the cornea, this is the epithelium of the cornea, and this is the endothelium of the cornea. You can see precipitation of iris pigment on the endothelium of the cornea. This is a shedding of the pigments from the periphery of the iris due to the wrapping of the periphery of the iris with the zonules. If we examine patients with pigmentary glaucoma or pigmentary syndrome by coaxial slit lamp light through the pupil, so you can see there is a reflection of the light from the posterior segment of the eye, and you can see illumination of the periphery of the iris due to the shedding of pigments from this area. This shedding is occur because of deepening of the anterior chamber and closed proximity between the periphery of the iris and zonules. This is one sign for pigmentary glaucoma or pigmentary syndrome. There is defect at the periphery of the iris and there is illumination of the periphery of the iris. Again, the treatment of pigmentary glaucoma is similar to the treatment of primary open-angle glaucoma. Congenital glaucoma is the last and the fourth type of glaucoma. According to the time of presentation, we can divide congenital glaucoma into three types. If the infant is presented with signs of glaucoma since birth, it is called true congenital glaucoma, and this represents 40% of cases with congenital glaucoma. If the signs of glaucoma is developed during the first year of life, it is called infantile glaucoma, and this is the most common type of congenital glaucoma. If the signs of glaucoma developed after age of 1 year up to the age of 16 years of old, this is called juvenile glaucoma. Congenital glaucoma is more common bilateral in 75% and more common in male than female. We should put congenital glaucoma for any infant or child presented with photophobia and watery eyes, in addition to more common conditions like nasolacrimal duct obstruction and conjunctivitis neonatorum early in life. Elevated of intraocular pressure in intrauterine life or the first 3 years of life can lead to increase the size of the eyeball as a whole and enlargement in the size of corneal diameter. So in this slide you can see there is enlargement of the corneal size in both eyes, which is called ophthalmos, and there is a corneal edema here in this eye because there is more rising of intraocular pressure in this eye, so you cannot see the details of the iris tissue. Also, you can see there is a sign of watery eyes in both eyes. Due to enlargement of the cornea, there is rupture in the descent membrane. So you can see these lines at the level of descent membrane due to huge enlargement of the corneal tissue. This lines is called Habs striae, which is sign of congenital glaucoma. Measurement of corneal diameter can be regarded as equal to the importance of assessment of visual field in patients with primary open-angle glaucoma. So corneal diameter more than 12 millimeter is suspicious in infant up to the age of 6 months. And corneal diameter more than 12.5 millimeter is suspicious for a child presented with age between 1 and 2 years. And if the corneal diameter is more than 13 millimeter is suspicious for any child presented with other signs of glaucoma in age more than 2 years. This is an infant with congenital glaucoma, so you can see ophthalmos, also corneal edema because you cannot see the iris details clear, also watery eyes, and this is the way to measure the horizontal and vertical corneal diameter. The etiology for congenital glaucoma is dysgenesis of the anterior segment of the eye and poor cleavage of the angle of the anterior chamber, so there is no way to drain the aqueous from the eye. For this reason, the only treatment for congenital glaucoma is surgery, and there is no rule for medical treatment because whatever you decrease the secretion of aqueous from the ciliary body, there is no way to drain the aqueous outside the eye. And also because these drops, for example, beta blocker, can induce severe side effect. Surgery should be done as early as possible because any delay for surgery lead to more destruction or more damage to the optic nerve and even might reach the state of blindness. Till this time, we have 3 methods, surgical methods for treatment of congenital glaucoma, which are goniotomy, trabeculotomy, and trabeculectomy. And in the following slide, I will give you just an idea, just for your knowledge, to know the main steps of these types of surgical treatment of congenital. Under general anesthesia and by using one of special type of gonio lenses to visualize the angle of the anterior chamber, and then by special knife, by special spatula, we do incision here in the angle to create a direct passage from the anterior chamber into the Schlemm canal. This is called goniotomy. If there is corneal edema or corneal opacification and we cannot visualize the structure of the angle from inside by gonioscopy, so we can do our surgery from outside and we pass special spatula inside the Schlemm canal, like in this case. And then in the following slide, you can see we can moving this spatula inward toward the anterior chamber to open the Schlemm canal directly to the anterior chamber. This is called a trabeculotomy. If there is corneal edema, corneal opacity, which make visualization of the angle and goniotomy difficult, there is a second method of a treatment which is called trabeculectomy, and I think we discussed trabeculectomy previously in a previous slide in lecture number 1. This is the last slide for glaucoma, and thank you very much for your listening and attention.